in a pediatric cataract. And we go on to Dr. Amit Porwal, awarding Tsunami in mature intumescent cataracts.
So thank you. Can we have the mic, please? Yeah. So thank you, Dr. Mohan and the chair for inviting me for this talk. So I'm going to talk about how to avoid the tsunami in mature intumescent cataract. And what do you mean by tsunami? Tsunami is basically prevention of the Argentinian flag sign, which most of us encounter when we are doing cataract surgery in mature intumescent cataract. So what are these intumescent cataracts? They are basically swollen, congested, there's a hydration of the lens matter, and there's increased intradenticulair pressure. And because of this increased intradenticulair pressure, the capsule is more stretched, the anterior capsule become more convex, and what happens after that? The visibility of the capsule is hampered. We have to stain the anterior capsule. It is very, very important, because if you don't stain it, the elasticity of the capsule is so high that, and the convex anterior capsule will just give away. And what is this tsunami? The moment you puncture the anterior capsule, suddenly the capsule gives away in both sides, and because it's a stained capsule, it looks like an Argentinian flag, and that's why it's called an Argentinian flag sign. So this is very, very important. How do we avoid this complication, or how do we avoid the occurrence of this Argentinian flag sign in mature intumescent cataract? As we all know that CCC is an essential step in performing a phacosurgery, and when you have an extended CC, your phacosurgery becomes more complicated. So just sharing a technique which I am following, and I've been presenting and published this technique. So you can see this is a intumescent mature cataract with a stretched anterior capsule which is more convex. So staining of the anterior capsule is done, and you have to make sure that the entire anterior capsule is stained properly. Once the staining is done, why it is important? Because the trypan blue dye reduces the elasticity of the anterior capsule, and it makes the capsule more rigid. Now with the 2 cc needle, a 2 cc syringe on a 24 gauge needle, you just bend it like an L shape, enter into the center of the anterior capsule, stay there, remain steady, should not have any hand movements, and try to aspirate it. You can see the moment I am aspirating, the central part of the anterior capsule is becoming concave now. Why is that so? Because we have decreased the intradenticulair pressure, and this is the cut you get. Now if you are not steady, this cut will extend. So you have to be very steady, and again reform the anterior chamber wherever needed. Reforming the anterior chamber doesn't mean go on overfilling the anterior chamber with a cohesive viscoelastic substance. It should be adequate so that the anterior capsule becomes flat. Now there are different techniques. I usually use a capsulotomy needle, but you should be able to do the rhexis with the help of a capsulotomy needle, a rhexis forceps, through the right hand, through the left hand. You have to be versatile. So in this case, you saw initial nick, it was given, and then I started with the small rhexis. Always it is better to do a small rhexis. Once you have better control of the anterior capsular flap, then you can extend the rhexis like a spring onion type or the snail ring pattern type of the rhexis. You can see I started with the small rhexis, now I have gone beyond the initial point, and I am trying to peel off like the skin of the onion. So this is a this is a snail pattern rhexis. Throughout, you make sure that the anterior capsule is flat. It is always advisable to make sure that you use a cohesive viscoelastic substance. Never have large tears, have small tears, and have a controlled movement whenever you are doing these rhexis. So you can see you have decreased the intradenticulair pressure, and how you get a well-centered rhexis. Sometimes you get a decentered rhexis. Nothing to worry after you have implanted the IOL. With the help of a micro 1 forceps, always give a tangential cut, never give a radial cut, and with the help of a micro rhexis forceps, you can just refashion the rhexis to the desired size and shape what you want. So if you are comfortable in doing a phacoemulsification, even in a small rhexis or a decentered rhexis, don't worry about it. You can refashion the rhexis after you have implanted the IOL, and you can get a good optic coverage of the anterior capsule throughout. Again, that's what I was trying to tell you. You should be able to use right hand, left hand, a capsulotomy needle, a micro rhexis forceps, and a micro 1 forceps is must in your cataract tree. One more case I am showing you, also you can see how intumescent this cataract is, how stretched the anterior capsule is. Staining of the capsule has been done. You can see I am injecting I am piercing the anterior capsule with a 24 gauge needle mounted on a 2 cc syringe. We had done a study in which we used a 1 ml syringe, we have used 5 ml syringe, we have used a 26 gauge needle, we have used a 30 gauge needle. But what I found was 24 gauge is adequate, because sometimes the fluid is turbid, so it doesn't get aspirated. So you saw when the moment it got aspirated, it's concave in the center, but you can see in the mid periphery, the slight bulge is there. So now when you are fashioning your rhexis, you have to make sure that you are at the highest point or within the highest point. If you just go beyond the highest point, this will give away, and there will be an extension of the rhexis. So you have to make sure you are within this within the highest point, the mid periphery what is there, and try to perform the rexis. You saw I was doing the rexis from the left hand through the side port because my initial nick was not in a proper direction. I didn't go through the main tunnel. So you have to make sure that at what particular time, which side port you are going to use, what instrument you are going to use. Throughout the whole capsular rexis, give some extra time when you are performing the rexis. Always make sure that you use a cohesive viscoelastic substance. Never go for an HPMC. Another technique to reduce the intraventricular pressure is basically you can do a YAG anterior laser capsulotomy. You saw I gave one shot of 1.2 millijoules right in the center of the anterior capsule, and there's a gush of liquefied cortex which is occurring. You can see like a waterfall, it goes on coming. So you do this procedure in your OPD, then shift the patient to the OR. By the time the patient is in the OR, he is lying down, the whole cortex has come down, the intraventricular pressure is decreased, and then your surgery becomes comfortable. So this is another use of this YAG capsulotomy laser what we have. We can use this in mature intumescent cataract, but make sure you give only one shot in the center. What happens when you give the one shot in the center? You get a stellate opening. You can see the stellate opening. After I stain the anterior capsule, after I have done the YAG laser capsulotomy, there is a stellate opening, and then you can continue with the rexis. We have done this study. We have calculated the pre-YAG ASOCT and the post-YAG ASOCT, and definite increase in the ASOCT in the anterior chamber dimensions is there. It has been published as a role of preoperative ND-YAG laser capsulotomy in mature intumescent cataract, and was also featured in the AO Academic Express of the Asia Pacific region. I also won the best physical poster award wherein decompressing mature intumescent cataract. Various techniques were compared in which the YAG laser was done, in which double rexis was done, needle aspiration was done. So we have compared lot of multiple parameters, and we had presented this. So the best tip to avoid a tsunami in mature intumescent cataract is to decrease the intraventricular pressure. At any cost, you have to decrease the intraventricular pressure, and how can you do it? You can do with the ND-YAG laser anterior capsulotomy or through a slow and cardiac decompression of this raised intraventricular pressure. So thank you, and thank you for the time allotted.
Thank you, sir, for that wonderful